Awesome. Okay, we'll just wait a couple seconds for some people to join. While we're waiting though, as per usual, if you guys have any questions, definitely go ahead and type them in the chat or Q&A box, and we'll spend some time at the end of the presentation and go over a few of those. All right, let's get started. So welcome everyone to Arthritis 101. Is it inevitable? Tonight we have Dr. Erik Nelson from Nirvana Naturopathic Clinic here in Calgary. So let's just start right away and talk about kind of the different types of arthritis and what that shows up in the body.
Perfect. Well, welcome everybody. Thanks for joining us. And for everybody who's joining us virtually later on, thanks for coming. So arthritis, there are actually a little bit arguable, but there's probably about 100 different types of arthritis if you go through each single one and you delineate it one by one. So there's different types of infectious arthritis, which is exactly what you think it sounds like. You either get infected by bacterial infection or viral infection, and you get that infection actually cultivates in a joint and starts to destruct the joint over time. That's actually can be a medical emergency depending on the type of infectious arthritis. So that is one that if you know you have it, you got to go to the hospital. It's not one to play around with. Most common arthritis is actually osteoarthritis. That's actually the most common arthritis. One of the most common conditions, period, that affects Canadians and North Americans or everybody worldwide.
Yeah. Is osteoarthritis then kind of 65 and over? Is it quite common, or is it becoming more popular, like not popular, but diagnosed in the younger population?
Yeah, so osteoarthritis, we used to think of it as just as a disease of old age, right? It was just associated with old age. That's not always the case. So there's two different types of osteoarthritis. So again, everything kind of delineates here. The one that we used to associate with old age is actually called primary osteoarthritis. And it's just where we don't really know what causes it. It's idiopathic. It just kind of comes with age. And they used to think it was really just related to wear and tear, but probably has more to do with chronic inflammation and dysregulated immune system in the area, leading to improper healing over time. So you can imagine like a 65-year-old has had a lot of wear and tear, of course, but they've had a lot of opportunity to have small little injuries inside of a joint that don't heal properly each time it gets healed. So you kind of little injury, little heal, little injury, a little bit of healing. And over time, if that healing doesn't keep up, so the regeneration in a joint doesn't keep up with the degeneration in a joint, you eventually lead yourself to what's called primary osteoarthritis. However, you can actually get osteoarthritis in your 20s or your 30s, which is kind of scary to people. It's the exact same process, but usually caused by something severe. So you can imagine trauma is the most common cause. You get into an accident, or like yourself, you may have had an injury, right? You have a recent injury. Let's just take your knee, for example. You have an injury, it really hurt the meniscus, something inside of the joint itself, inside the knee joint, caused a really, really aggressive immune response, a lot of swelling, a lot of internal damage. And if that doesn't heal well, you can actually get a really, really boost in your degeneration, a big boost in degeneration, and a basically, if you doesn't heal well, you don't get enough regeneration in time, and then you can actually lead to getting osteoarthritis really early. The more severe the trauma, the faster that happens. So that process can be due to several smaller traumas in a row that didn't heal well, or it could be just due to one really bad trauma. Let's say you had to get some surgery after it, and then you probably had multiple injuries your body's trying to heal from. So depends on the history, can happen earlier. Some of our listeners are probably looking back into their history and going, yeah, I did, I fell off a horse, or I got into a car accident, or I had a skiing accident, or I was playing volleyball and I twisted my ankle, and now maybe that led to my ankle pain now 15 years down the road or 20 years down the road.
Yeah. So what about then symptoms? Like, are there clear signs, obviously with injury, you get that acute kind of swelling and pain. But with osteoarthritis, let's say, versus rheumatoid arthritis, kind of what are those different symptoms that show up?
Yeah, great question. So maybe I should have led off with this. So when we're talking about arthritis, we're really just talking about inflammation inside of a joint. Now, that inflammation, like the infection, can be really, really acute, can cause very sudden, severe symptoms, which in those cases would be pain, usually pain, swelling. So swelling will look like a bigger joint. It'll feel like it's full of fluid. It'll often be warm to the touch. Can be discolored. And honestly, sometimes it can be so bad that you can push on that joint and you just notice it pits, which means that the actual skin will kind of indent and then it'll slowly come back up. And that would be considered a pretty significant type of knee effusion or ankle effusion or whatever joint you're talking about. So the main symptoms that a patient will report is usually pain, maybe the swelling. So it's hot, it's tender, it's large. The key one that's a differentiator for me clinically is actually stiffness. So stiffness is something that a lot of us experience, and we can experience it at different times of the day for different reasons. But if the stiffness is localized to the joint, it tells us a little bit about what type of arthritis we're dealing with. So a hallmark for rheumatoid arthritis, like what you just talked about, which is a type of autoimmune disease, it's an autoimmune arthritis where the immune system's actually attacking your own cartilage cells in the joint. And rheumatoid arthritis will cause pretty significant stiffness that actually lasts up to 2-3 hours in the morning. So let's say you wake up in the morning, you're feeling a little stiff, you get up, you take a couple of steps, and with osteoarthritis, that stiffness will actually go away typically within 5 to 10 minutes of warming up, right? Rheumatoid arthritis and other types of true inflammatory arthritises like infectious arthritis as well, they all linger. That stiffness is there. There's so much fluid in the joint that it just sticks. And it takes them a lot longer to quote unquote feel themselves, to feel normal, feel like they're walking normally again. They don't have a limp, for example. So those are the big ones: pain, stiffness, and swelling.
And so then what would be like the diagnostic approach to kind of determine which type of arthritis you have?
Yeah, great question. So diagnostically, it's a clinical exam. So your doctor is going to assess you. Really, 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 really important that they do a full physical assessment of the joint. They compare a healthy joint versus an unhealthy joint, right? You always need to know where your baseline is. So the physical exam is going to tell us a little bit of information. And then in order to actually diagnose, for example, osteoarthritis, which is the most common, you need an X-ray. And you could get an MRI that would definitely show it. However, the classical diagnosis is based on a plain 2-view X-ray plus symptoms. So that's simple enough, right? Rheumatoid arthritis is difficult. The diagnosis requires some additional blood work. So you might be able to see that they have some arthritis evident on X-ray, for example, that might have signs on that X-ray that point to more of an inflammatory arthritis like rheumatoid arthritis, but nothing is diagnostic there. You just go, it's arthritis, not sure which one, let's do some additional lab work. And so for rheumatoid arthritis, there is a few classic blood markers. You're looking for rheumatoid factor, anti-CCP antibodies, and then a couple of other ones to rule other ones out. But basically you get the diagnosis with the lab work. So in that case, it's the most advanced. There are examples. So if anybody's heard of gouty arthritis, that can happen, your big toe can actually happen in your knee, can happen in multiple different joints. That sometimes requires the doctor to go in with a syringe and actually pull out, it's called a joint aspiration. So we pull out some fluid and then we can analyze that fluid under a microscope and see if there's crystals in it, because gout is actually a crystalline arthritis. So those crystals are basically poking at your tissue, causing severe pain and inflammation. And they can tell what type of gouty arthritis it is from that joint aspiration.
That sounds very painful.
Yes. Yeah. And maybe before I move on from that, because gouty
Yeah.
arthritis is probably not one that's going to come up a lot, but it's
Mhm.
actually pretty common. Gouty arthritis, you have. It's going to come on overnight. It's usually really, really painful. And it requires you to go to the doctor. It's that painful. It's not one that you're going to grin and bear it and just go, it'll pass. So gouty arthritis is going to be in your face. You're going to go to the doctor. You're going to say, hey, my joint is really, really painful. It wasn't that bad yesterday. What's going on? And oftentimes the standard of care is simply to give you an analgesic medication, right? Or for that specific disorder, it's just a high dose NSAID analgesic. And it works really well. And so they don't actually go through a lot of the testing. They might do it after the fact, but they need to deal with the pain in the immediate circumstance.
Mhm.
And they won't send you for an x-ray right away. They won't send you for lab work right away, or they typically won't. They won't pull your fluid right away unless they absolutely need to in a hospital, for example. For the most part, they're just going to treat right away with basically anti-inflammatories in that case.
Right. And with gout, like I'm just thinking of rheumatoid arthritis, it usually shows up kind of in like both, like if it was your fingers, kind of your left and right, or wrists left and right, where gout is usually just one.
Yeah, exactly.
Or something. Yeah.
You're right. Yeah. Again, there's different types of gout. There's gouty arthritis. There's pseudo gout, which can happen in different joints. That's where a clinical exam really helps. Like if you're struggling with this, coming in to see the doctor is actually very useful, because it's a little bit of history and you get to figure out which one it is. Rheumatoid arthritis can be difficult to diagnose, even for experts, simply because if you don't have the labs that say you have rheumatoid arthritis, and you're not sure based on the x-ray that says you have rheumatoid arthritis, you can still have rheumatoid arthritis. So you can, it's something called seronegative rheumatoid arthritis, and it's typically a diagnosis of exclusion. So the doctor has to go in and exclude several other causes of arthritis. One of the most common ones that you'll have to exclude is called psoriatic arthritis, which is associated with psoriasis. So if some of our listeners here, they have psoriasis, which is a common skin condition. If you have joint pain and it's affecting multiple joints on both sides of the body, similar to rheumatoid arthritis, could be psoriatic. And in that case, again, lab work is going to be very helpful. Treatment is going to be slightly different between those two. So it's really important to actually get that diagnosis.
Yeah, speaking of treatment, osteoarthritis versus rheumatoid, I'm assuming they have very different treatment protocols. So maybe walk through some of those for us.
Yes, very different. So like I said at the beginning, arthritis is considered joint inflammation, but the levels of inflammation between these different types of arthritis can be 100-fold, 1,000-fold different. So rheumatoid arthritis is so inflammatory that the standard of care is actually direct anti-inflammatory, pretty heavy duty stuff. Different types of steroids, different types of biologics, and different types of, they're called DMARDs, which is disease modifying agents of rheumatoid disease. They actually stop the immune system in its place, which is very effective for treatments, but they come with a whole host of side effects, right? You need to be monitoring the fact that you're suppressing your immune system is going to have issues when you're fighting infection, for example, or you're fighting cancer, you're screening for cancer. So treatment for those are a little bit more heavy-handed for the most part. I'm just going to talk from my perspective, because here in Alberta as naturopathic physicians, we don't prescribe. So we always do natural therapeutics, and we try to empower our patients to take steps in their own life that will actually give them a sense of control over what their disease is, whatever that disease may be. So in rheumatoid arthritis, I have a lot of patients who come in, they're being co-managed by their family physicians or rheumatologists, but they're getting really good benefits simply by identifying triggers in their environments and avoiding those triggers, whether that's food or it's air pollution or it's mold exposure. Those triggers can be really, really common, leading to flares. So triggers of a flare up of their disease, which might mean that they have to go on one of these heavy medications. So if they're working with me, I'm really trying to get them to have as few of flares possible, few flare-ups as possible, make sure that those flare-ups don't last very long and that they can still function while it's happening. And so we have a lot of anti-inflammatory natural therapeutics that we employ, as well as identifying and removing triggers in their environment. And then just I don't know if you had follow-up questions about that.
I was just gonna say, it seems like the people that I know with RA, the flares are usually stress related too. Like there might be a big stress, and then inflammation can kind of just jump up right away. So kind of managing stress too.
Absolutely, that's a great one. Yeah, because stress is gonna impact your immune system directly. So it's keeping you steady. Your immune system might be up and running, and if you have very stressful time, or if you have poor sleep, for example, or poor nutrition, all those things can decrease your immune system for enough time for that disease to flare and present itself again.
Right.
Yeah. And then our osteoarthritis is not that inflammatory. It technically does have inflammation in its pathogenesis, which is important. It's one of the reasons why a lot of people will just pop Advil and over-the-counter anti-inflammatories, because it can work, as do some anti-inflammatory herbs like Boswellia and turmeric. If you guys have heard of those ones, very common herbs that are used in osteoarthritis. They're used because they tend to have an effect. They don't work for everybody. Some people don't really have, I would say, a lot of inflammation, and you can kind of assess that on your physical exam. But if you're trying things at home and you have these things in your cupboard, for example, or your spice cabinet, you can actually just give that a go and see if that helps you, whether it'll decrease your severity. It might just decrease the amount of stiffness you have in the morning, and that could be a win, right? But osteoarthritis has a big component of just slow and steady degeneration, right? So what we are trying to do, I would say two different goals for my symptomatic osteoarthritis patients. Number one is to address their symptoms, right? Because a degenerated joint in and of itself is not actually the problem. It's generally not the main goal of treatment to reverse that, for example, because you could take the next 100 people you see on the street, you could x-ray their knees, or you could x-ray their back, or you could MRI their back. I can pretty much guarantee you that 60% of them or more are going to have some radiological findings on those reports. And most of those people are not going to be symptomatic, right? So just because it's there, just because it's degenerated, doesn't necessarily mean you need to treat it. But if it's symptomatic and degenerated, that's where we need to actually start doing something about it, right? Don't just live with it and wait, and then it ends up being bone on bone. And then the last treatment, the definitive treatment, which would be a complete joint replacement, is upon you, right? So I'm really trying to work with my patients when they're in the mild, moderate, severe, and severe but resistant to surgery people. So, but those people I'm really working on trying to change the ecosystem within the knee itself. So really, really simple things that you can do to change the ecosystem itself is, one, get good blood flow in and out of the area. And it's not as easy as it sounds. It's not like muscles where you have a really, really good blood supply. Joints actually have really terrible blood supply. They typically get nourished through movement alone. So if you're laying in bed and basically when you're sleeping, you're actually not getting a ton of blood flow in and out of the joints. You need some motion. Like motion is lotion. I talked about that with my patients. Motion is lotion is relevant in osteoarthritis because you need to actually push nutrition into the joints, in and out, in and out, in and out. And so taking a cue off of a lot of other practitioners like our physio friends and chiropractor friends, one very, very common treatment for osteoarthritis is to get people to start cycling or swimming. And the reason they choose cycling is because you can get a lot of repetitions. You can choose how much pressure you're putting through the joint. So if it's too painful to walk, it's too painful to run, you might as well get something where you can just put a little bit of pressure through the pedals, like like cycling. If you can't do cycling, maybe swimming might be better, right? If your shoulder has the arthritis, swimming might be a little bit better too. So motion is lotion, getting actual nutrition in there. Dealing with the other aspects of health, which we talked about a little bit before, but inflammatory processes, the immune system health is going to be impacted by sleep, nutrition quality, certain supplements. So if you think about a really common one, I'll just bring it up now, glucosamine. Glucosamine sulfate is like the most popular supplement in the world for osteoarthritis, and it has really mixed results. But the big problem with glucosamine is people think of it as a treatment for arthritis or a treatment for osteoarthritis, as that it's going to actually take away their pain. But glucosamine is simply just nourishment for the joint. It's just helpful building blocks that the joint needs. So if you're giving yourself glucosamine sulfate or glucosamine or chondroitin or MSM or even Boswellia or turmeric, you need to push it into the joint with a little bit of activity. Right. And then you also need the good immune system to go along with it, right? So sleeping enough, keeping your stress under control, all that kind of stuff plays a role. And then you can go into, with arthritis, once you're at the higher symptom side and your symptom side, you really need to address those things because it's going to affect your quality of life. That's what I typically do day in and day out. Is I'll do regenerative injection therapies like prolotherapy, for example, is very, very common type of a therapy that will actually help change the microenvironment inside the joint. It kind of boosts the regenerative capacity inside the joint for a certain amount of time. So if you imagine osteoarthritis is like degeneration has gone really high, or it's stayed high for a decent amount of time, and your regeneration is low, you have this slope towards your joint just getting worse, right? Degenerates more over time. Prolotherapy really boosts up that regeneration for a little bit of time. And so at the very least, it's stopping any more degeneration from happening, which can be really helpful. Yeah. But it actually there's been at least one study that has shown actual regeneration of tissue within the knee joint, which is very, very, very hard to do. There's no other therapeutic, there's very few other therapeutics that have been proven to do anything actually to do with regeneration in the joint. So that's one of the reasons why I love doing it. Main reason I love doing it is that it helps people get out of pain and it actually works. And we got plenty of clinical data to support that. So
awesome. And in terms of pain, is there any other like supplement? Because you were saying, Boswellia, MSM, things like that don't technically help with pain. So if someone's looking for more pain management, is that maybe willow bark or devil's claw or something like that?
All of them are actually, so Boswellia there's a few clinical trials using it for symptomatic osteoarthritis, and it does help with pain. So it helps with both pain and function. So Boswellia is actually one of my go-tos. Same thing with turmeric, typically used as a combination product with other anti-inflammatories. White willow bark has a little bit of data on it. Typically people are just going to end up on NSAIDs. White willow bark has some benefits over typical NSAIDs, and that doesn't affect the stomach lining, for example. So if you have been told by your doctor not to take Advil, even though Advil works for you, that might be a runaround, if that makes sense. So that would be the case that I use white willow bark or a white willow bark formulated product. So typically when I'm doing supplements, especially with pain, I'm going to use a combination product most often, and I'm going to be dosing it short term, see if we at a high enough potency, see if we get an effect. If we don't get an effect within a few days to 1 to 2 weeks, you're going to go on something else.
Yeah.
Okay. Those are the therapeutics I'm just directing for your pain. So if the pain's not getting any better, then why are we on it, right? Different when you're talking about taking collagen supplements or glucosamine, those types of things. Those are really just nourishment for the joint. All of the studies that show positive benefit for those are months. They're not weeks. They're not days. Yeah. So, if you feel it improves your symptoms in 2 days, like good for you, but that's not the norm. The norm is actually they come back, they go, doc, I don't really notice any difference with this collagen. I say, well, collagen really takes about 2 to 3 months to work. Glucosamine usually about 6 months to work. And typically I have those supplements on somebody's supplement plan for a year or more.
Right. And that's type
Yeah.
2 collagen you use?
Yeah,
or?
typically I like type 2 collagen. Collagen research right now is kind of fun to look at. It's kind of crazy. There's actually type 2 collagen is the one that we thought was the most important, simply because it's the most abundant in the actual chondrocytes in the knee joint itself. But there's multiple different types of collagens. They're all important. And so typically when you're getting a blended collagen product right now, the ones that have the most data support them are type 2 collagen based on chicken sternum. I know that's kind of crazy, but it's chicken based products. Marine is probably the second best, and then bovine is probably the third best source of those. But again, that research is actually changing rapidly.
Yeah, it's definitely still very popular. But it seems to, yeah, like you said, work for some people and maybe not others. So
Absolutely.
Yeah. What about SAMe? Do you use that for osteoarthritis patients?
Yeah, actually it's useful, again, as a combination product typically. I'm going to put that into a full, what I would call a nourished joint formula. So it's going to be included in with the other ones that we already mentioned.
Awesome.
Yeah, not typically on its own.
Oh, okay.
Yeah.
So do you typically then recommend kind of your supplement blend and then the prolotherapy together is kind of the best support for that?
Yeah. So my therapeutics, I kind of hesitate to give a broad base because it's pretty individual depending on the type of arthritis somebody has and what joints they're affecting. The prolotherapy is common because I can cater it to the person, right? I can assess their actual physical structure and see what tissues need support. It's not just as simple as a cortisone shot, for example, where a cortisone shot, you're just going to put actual needle inside the knee joint and just put this solution in there and then pull the needle out and you're done. Typically with prolotherapy, you're not just treating inside the knee joint. Yes, I'll go inside the knee joint, put the fluid in there, but I'm also going to be treating the structures surrounding the knee that are supporting the knee that are really, really important for the actual pain presentation for the patient sitting in front of me. So whether that's involving the MCL, the LCL, typically often the patella tendon or the quadricep tendon or underneath the patella, as well as treating some of the nerves in the area that supply the sensation in and around the knee joint. Kind of need to treat those as well because they can be affected by degeneration just like every other tissue. You can kind of imagine if you take a joint and it degenerates over time, it'll shrink, right? So you actually get a loss of height. And you can imagine the ligaments that support that joint actually get a little bit lax, right? Because now there's not as much tension pulling on them because the joint's just smaller. And so those tissues can be pain generators by themselves. So if you're just treating inside the joint, you will very often miss the most important pain generator for a patient. So prolotherapy is treating multiple structures almost always. Very, very few times I'm just putting into a knee joint and calling it a day. Now with that, I'm always giving some sort of physiotherapy type exercises, whether I'm the one delivering that or I have a PT working with them. That's going to be really important, or a personal trainer that we trust. Definitely want somebody on board to keep them accountable for movements, so specific movements to make sure that we can support, again, muscles are going to be crossing those joints. And so making sure the muscular integrity as well as the neurological function of those muscles is working properly. That's a big key. That's a big piece of it. So those are pillars that are almost always involved. The supplements are almost always a adjunct thing. It's not something that I'm going to say, this is going to be by itself going to cure you in any way. It's just going to be helpful for us long-term. Let's maintain the progress that we have achieved and let's kind of keep you going in the right direction. The The other things that I'm going to add on typically is low-level laser therapy. And it just has tons of research on it. Very, very useful. There's actually research using low-level laser therapy with glucosamine, and it actually makes both of them work better, which is really, really interesting. I wouldn't have even thought that. But low-level laser therapy can be useful because it helps increase blood flow to the area, helps improve essentially the energy production of the cells that are trying to actually heal, right? And it can decrease inflammation directly. So low-level laser therapy plus prolotherapy plus exercises plus some additional homework that I'm going to give you, and then the supplements typically.
Right. What about diet? It's common, nightshades, things like that come up quite often when people talk about arthritis.
Yeah.
What's kind of the research on that? Do you typically recommend people to avoid that? And then what kind of dietary recommendations do you make?
Yeah. So if you hear my dog growling there, hey buddy, you need to get out there. Can you hear him at all or no?
No.
Okay, good. He's growling. So dietary recommendations, really, really simple. For nightshades, just to talk about that, nightshades can affect people with arthritis about 1 in 20 cases. So about 5% of cases actually are clinically responding to something in the nightshade family. And it's typically not the whole nightshade family, to be honest. It's usually a handful of them. So with dietary triggers, again, that's more of the autoimmune types of patients. I'm really, really cognizant of personalizing that to them. So identifying those triggers, usually not that hard to identify the triggers. It's really about making sure that you've identified all of the triggers, and then you're removing them, and then potentially slowly bringing them back in your diet if you think they're okay over time. The big overarching categories with diet, though, are you need to be making sure you're in an energy balance. Okay, so if you're really, really low on calories and you're trying to heal from an injury or trying to heal from any type of degenerative process, it's hard. Your body is not set up for growth and repair when it's struggling with calories, right? So if you're trying to lose weight, now that can be tricky because weight loss is one of the best treatments by itself for arthritis related to obesity. So osteoarthritis, I actually have had patients who were on the queue for total knee replacements that do not need knee replacements anymore, simply because they lost enough weight. Now they were, quite obese. They needed to lose a lot of weight. And so losing, in their case, 30 to 40 pounds was enough to really take most of the pressure off of those joints. And I think most of that actually is the actual decrease in inflammation, improved blood flow, improved nourishment in and out of the joint, as well as the decreased load was useful. But again, those patients aside, so unless your doctor has told you that weight loss would be helpful in your specific case, making sure you're at a calorie at least at neutral, right? It's going to be helpful. Number two is making sure your protein, you don't need to go crazy with protein, but you need to have enough. Okay. And clinically speaking, it's like 1.2 to 1.6 grams per kilogram. That's kind of the sweet spot. Anything above 1.6, I've never seen any research say it's better. I understand the bodybuilding community and people that will go way, way higher than that, but I've never seen any research say better than 1.6. But there is benefit going from the recommended daily allowance of protein, which is 0.8 grams per kilogram. There is benefit for those people boosting up to 1.2 to 1.6. And typically, if you're going to be doing that, it's not about just having like a giant steak at dinner. It's really about making sure you're getting 20 to 30 grams at each of your main meals and spreading that out through the day so you get the biggest bang for your protein buck, right? So those are three. And then the third pillar, so those are two. The third pillar really is the anti-inflammatory piece. And so the anti-inflammatory piece, there are classic ones. So cruciferous vegetables is a classic one. Most fruits actually are beneficial in osteoarthritis. They just have very unique compounds that you're not going to get in other types of foods. So for example, blueberries directly have been studied in osteoarthritis, and they've been shown to be helpful. Sesame seeds have been shown to be helpful. It's kind of an interesting one. Even sesame oil, there's something in the sesame oil itself that's useful. Cruciferous vegetables, cabbage leaf has been put to the test, found to be helpful. But I'm just gonna usually help patients with their overall diet to include those things, because I want my patients to be on these things and like eating these things anyways.
Yeah.
Cardiovascular health and bone health and, you know, hormone metabolism and everything else. So they have a lot of reasons for them to include that into their diet. So
Yeah, that's interesting. I didn't think of it from that perspective of, the fruit providing certain nutrients. Yeah, because so many people are doing low carb or keto, right? But diet very specific to the individual and kind of what they need. So yeah, that's really interesting.
Yeah. And I would really, fruit is absolutely, I challenge readers to go and if you're savvy with PubMed, for example, and looking up, or Google Scholar and looking up research, try to find a single study that shows that whole fruit consumption as a negative outcome.
Yeah.
So when I taught back at Southwest College of Naturopathic Medicine with my students, I would ask them that question, and we never found one. It's really odd that it's come up as potentially unhelpful for some people.
Mm-hmm.
But it's really, really, really difficult to make an argument against fruit, especially things like berries, which have, direct evidence of help, of support, right?
Yeah. Yeah, that's awesome. You don't need an excuse to eat abundance of fruit, so that's good.
Yeah.
Awesome. Okay. Maybe we can get to some questions here. There are a few. I have osteoarthritis in my hands. Should I be concerned about my other joints getting it?
Yes and no. So osteoarthritis in the hands is interesting. It's more common in women. It is more common in manual labor. So there is a little bit of an aspect of wear and tear, quote unquote. And I think that has a lot to do with just not giving your body enough time to heal from specific stress or specific strain. So I wouldn't necessarily be concerned that you're going to be ravaged by arthritis in other joints, because you may have been a little bit more reliant on your hands, for example, over the years than you are your ankles or your knees or your hips, for example. And you could have been nourishing those bigger joints really, really well, but not nourishing your hands very, very well. So a really common cause of this is actually thoracic outlet syndrome. If people have heard of that, I don't want to go too much into it, a completely other topic, but essentially anything that's affecting blood flow to the hands. So you imagine there's a lot of conditions actually that affects blood flow to the hands. Well, you need good blood flow in order to regenerate after stress. And that is going to set you up for success. So if you're not getting good blood flow for whatever reason, then you're actually at a higher risk of getting arthritis in that specific joint. But if it's happening in your hands, doesn't mean that it's happening in your spine, doesn't mean that it's happening in your back, doesn't mean that it's happening in your feet.
Right. Yeah, I think even that just, I remember reading something about how someone had osteoarthritis in their knee, but actually their hip was causing a lot of those issues, just that misalignment, even, right? And they didn't realize they're focusing on their knee, but the hip was the biggest issue. So getting a proper assessment is really key in that regard.
Yeah, I'll say two things about that real quick. One is, just because you have knee pain doesn't mean it's coming from your knee.
Mm-hmm.
So many people, that pain is not coming from the knee, it's from their back, could be from their hip too. Number two is, any compensation pattern can be problematic, right? We are compensating machines. We are resilient people, right? You might have a little irritation, stiffness, pain in the hip. It will affect the way that you walk. It will affect the way that you stand in order to just be the most relaxed. It might affect the way you sleep. And all those things might put abnormal pressure through the other joints. So including your knees or your ankles, for example. It's very, very important that you address each one of your areas of pain, get a physical assessment so that you can get a holistic picture of what's the primary cause of your pain, what's the secondary cause of your pain, and where should we start?
Yeah. Do you, because some practitioners recommend NUCA, the chiropractor care. Do you find that helpful for just a full body kind of reset almost?
Absolutely. I'm a big believer in physical medicine in general. I rely on a lot of chiropractors, including NUCA chiropractors. We refer back and forth quite a bit, but all types of body workers, and that includes our osteopaths, our massage therapists, our physiotherapists. Really, if you have somebody that knows what they're doing in that realm, hold on to them, use them, like get ahead of the game, get as balanced as you can, and get regular work, because that'll help you prevent things like arthritis in the future.
Yeah, absolutely. All right, are gluten and sugar the most common triggers?
No, not necessarily. Certainly not. Sugar is not going to be typically helpful for anybody, but it's not always a common trigger. Interestingly enough, like I said, with triggers, it's actually, for the most part, if you actually track your diet plus your symptoms, it's not that hard to figure out your triggers. Sometimes it's hard to figure out all of them, but something like sugar and gluten, pretty easy to figure out if that's affecting you specifically. And gluten is one of those things that it affects enough people that if I made the blanket statement, everybody should avoid gluten and sugar, 5% of people are going to benefit from that recommendation, roughly 5%. 95% of you are, you're going to be avoiding things that might not be at all related to your pain picture, right? As far as for a trigger, gluten has been a trigger for a lot of my patients. I don't want to poo-poo that. That's definitely a thing, but it's not guaranteed to be a trigger for you. And that's the whole point of doing personalized assessments.
Yeah, absolutely. Do you have to be careful with Boswellia and white willow bark if you are on a anticoagulant or if you're intolerant to aspirin?
Typically, I'm not worried about those things, especially Boswellia, not so much. White willow bark, very, very. The reason why these things are considered potential interactions with these drugs is that there's a mechanistic data that we know about, right? It's not because we have clinical data that when you use these products, you see increased risk of bleeding disorders, for example, or increased risk of bleeding disorders while people are on anticoagulants. So there's theoretical reasons why you wouldn't be on it, but clinically, I've never seen it. And clinically, I'm also dosing these shorter term. Like I said earlier, I'm not typically using these anti-inflammatory type medications or herbals long-term, because that's covering up the pain. It's not figuring out why you have inflammation. It's not figuring out why you're in the spot you're in right now. That's covering it up. And I'm all in favor of getting people out of pain and getting them symptomatically in a place where they can function day to day. But while we're doing that, let's dig into figuring out what's causing your pain to begin with.
For sure. So can you use glucosamine long term? I've been on it for 16 years.
Yes, you're fine. 16 years. Yeah, you're fine. I haven't seen any studies on 16 years of data, but I've never heard anything wrong with that.
Awesome. Next question. How could we differentiate between fibromyalgia and arthritis? Does the same treatment work for both?
That's a great question. Fibromyalgia can cause widespread joint pain, right? Fibromyalgia is going to have other hallmarks. There's kind of 3 hallmarks in fibromyalgia. There's usually some sort of cognitive effect, right? So there's some sort of brain fog, a piece of it. There's the muscle pain, joint pain side of it. And then there's sleep disturbances. So there's 3 buckets, right? If you just have the muscle pain, joint pain part of it, then it's unlikely to be fibromyalgia, right? Not guaranteed, but unlikely. The treatment is actually different. Like I said, there's so many different types of arthritis. Your treatment for arthritis is going to be very targeted to what is causing your pain. But let's say you had rheumatoid arthritis or another type of autoimmune arthritis, where it's an inflammatory arthritis, some of those can actually move from joint to joint. It's called migrating polyarthralgia. It just moves from joint to joint. That can happen with different infections. It can happen with several different autoimmune diseases. It can also happen with fibromyalgia. Those are the types of patients that really require a thorough workup. You can't figure that out in 15 minutes. I can't answer that question in this webinar. It's actually quite difficult to untangle those things. And one of the reasons it's so hard to untangle those things is if you have fibromyalgia, it doesn't mean you don't have the other things. Technically, we used to think that fibromyalgia was only diagnosed as a diagnosis of exclusion, meaning that you guaranteed you didn't have any other disease. We don't know what else to call it. We're going to give you a diagnosis of fibromyalgia. Nowadays, we know that fibromyalgia goes along with a lot of diseases, including not most, but quite a few autoimmune diseases like rheumatoid arthritis. You could have both. Yeah, and that's tricky.
Tricky.
Yeah.
So again, proper diagnostics and figuring that out is key. So I have a bit of arthritis in my knees. I hike a lot. Am I helping or hurting my knees?
Movement is good. Yeah. So if you are hiking and you notice that you can hike up the mountain and then you're stuck because you can't hike down the mountain because you just flared up your knees so bad during the hike up, you're probably doing more damage than you are good. Okay. The rule of thumb I can just give you right now, a lot of PTs use this. I use this as my practice, is the 4 out of 10 rule. So if your pain is below a 4 out of 10 on the scale of 1 to 10, 10 being the highest pain you've ever experienced, 0 is you have zero pain, no pain. If you're above 4 out of 10, you might be doing too much too soon, right? So you might need to be doing a little bit more aggressive treatment, getting that pain score down, or you're just doing a little bit too much. So for example, if hiking and you feel it, let's say you feel it in your knees, it's discomfort in your knees, that could be a 2 out of 10. Again, this is your scale, not mine. My 2 out of 10, I consider that discomfort. My 3 out of 10, again, it's really just discomfort. I feel it, I know it's there. I can hike, I can go up the mountain, I can go back down the mountain. I'll probably be a little bit more stiff tomorrow. That's okay. That's totally fine. Actually, it's encouraged.
Yeah. I think then she said I walk until the pain is gone. I don't know if that is helpful or not either.
Yeah, I mean, if your pain is going away while you're doing activity, that's a good thing. There's an aspect to osteoarthritis where it's really just it's protein aggregation within a cold joint. So somebody over here, Cliff, also said cold weather worse than warm for osteoarthritis. Absolutely, cold is worse. And the reason is cold will cause stagnation, right? It'll cause a little bit of protein aggregation within a joint, and you need a little bit of movement and a little bit of heat in order to break that up, and then you feel better. So it's the main reason why people have stiffness in the morning as well. It's because the joint's cold. It's cold and there's some protein aggregation. So you get moving, you get a little bit of blood flow, you get the warmth to the tissue. Typically your symptoms will go away. And so cold weather typically is worse for arthritis as well. And you can imagine cold weather actually will affect joints more than anything else in your body. It'll affect it because the joint is so water rich. Like imagine it compared to your muscle right next to the joint. Your muscles are fine in the cold water or cold weather because they have good amount of blood flow, and that blood flow is at the temperature of your body. So it's nice and warm, it's 37 degrees. So outside, that cold air blows on a joint, starts to cool the actual tissue, the fluid within a joint. Inside the joint, it'll get just marginally colder, which will start to show symptoms.
All right. Yeah. Can you reverse arthritis if it's not severe?
It's hotly debated. Yes. And so I kind of stepped out of this debate. I taught a class on regenerative medicine. It's called Advanced Topics in Regenerative Medicine. And there was a big pushback in the whole field of regenerative medicine towards being called something different. And now they're kind of calling it orthobiologics, and they're using all the exact same treatments. Nothing has changed except for the name. And the reason why there was pushback is that it was very, very, very difficult to show true regeneration in a tissue. in a living human. It's pretty easy to do in an animal actually, but in a living human, it's quite hard to do. And very few studies actually look for it. So for example, if I look up studies on PRP, if people heard of that, or stem cell therapy, even if it's a 2-year study, might show really, really good benefits in terms of pain, dysfunction, stiffness, quality of life. But very few of them are going to ask for post-op biopsy. So after the study is over, their pain is feeling better, and they go, I'd like to now take a tissue sample of your knee so I can study it under the microscope to see if you've actually gained any tissue. Or I'm going to do another MRI. I'm going to get you to come on in and do a functional MRI to see if there's any more tissue. And generally speaking, there's very few studies that have actually done those post-treatment analysis, and very few of those ones that have been done have shown any type of regeneration. Now, I don't want to say there's no regeneration, because I mentioned it earlier in this podcast, in this webinar, that prolotherapy, there is a study that showed regeneration of tissue. And so it is possible. Now, the question is that tissue quite the same as the tissue was before? Like when you were 20 years old, is it like going back 10 years? Or are we regenerating a slightly different type of tissue? And for the most part, it looks like we're regenerating a slightly different type of tissue, which might not have the same wear characteristics that a beautiful 20-year-old joint might look like.
Awesome.
So again, let me just reiterate, it's not really the point to regenerate. The point is, let's say you have knee pain. The point is that you don't have any knee pain and you can live out your life without thinking about your knees. That's my goal. It's not really to say, I'd like to put you under I'd like to take a biopsy of your cartilage and see if it's growing, because I don't really care about that. If you feel good, you're able to do all of the hobbies that you want to do with your life. You're going into retirement and you're thinking, hey, I can actually hike those mountains and I can go golf and walk the course and not think about my knee. That's a win. That's kind of what my goal is.
Awesome. Okay, I have severe OA in my wrist, and I've tried everything, prolotherapy, injections, all sorts of herbal supplements. Do you have any advice for me, please?
Come on in to get an assessment. At that point, I'd like to see imaging to see what's left. So one of the reasons why prolotherapy, for example, might not work is prolotherapy requires you proliferate something. It needs some cartilage to work with. Otherwise, there's no response to it. It just is inert. So if you're so severe where it's technically bone on bone and there is very little cartilage left, then you're in a place where most of those injectables are not going to do much. Herbals aren't going to do much either. And so getting an assessment, making sure that your pain and dysfunction for the first off is actually coming from the wrist and nothing else. So there's no nerve in the area that's affected. There's no tendons, ligaments, any other tissue in the area that's affected. And if it is coming from the actual joint and there's nothing else you can do about it, that of course surgical evaluation is that's exactly when it's useful, right? There is no full wrist replacement though for you in the specific case, but I would say come on in, let's have a chat, take a look at your stuff.
Perfect. Have you found prolonged needle effective for severe OA? I'm lined up for a knee replacement.
Can you repeat that? Prolonged needle?
Prolonged needle.
So prolotherapy?
Oh, is that the same thing?
I'm not sure.
Not sure. Okay. Yeah, maybe if you could just clarify that, Ruth, what you meant there, but
yeah. So I'll say this. I have had a lot of patients who would be candidates for surgery who don't end up getting surgery. I'm not saying they're never going to get surgery, but the goal is to push it off. And it depends on your age, it depends on your health status, and it depends on your comfort level with surgery, because that's a big deal. I don't know if people really recognize the severity of getting a procedure like a total hip or a total knee replacement. I used to work in that field. Actually, I was a sales rep and an employee at the Symphonis, which is one of the largest orthopedic hardware companies in the world. And I saw literally hundreds of knee replacements, hundreds of hip replacements. I was in the operating room for a lot of these things. They can be life-changing. Symptomatically, they can be amazing, but they can also have significant side effects. It's a big surgery. And the reason why doctors here in Canada don't even really consider you a candidate for surgery until you're 65 for joint replacement is because, this sounds weird, but they want you to die with the joint replacement, the first one. The first joint replacement you get, so if this sounds weird, if you get a knee replacement or a hip replacement, a good outcome is that it'll last you about 15, maybe up to 20 years. So they want you to be old enough before you get that surgery that you will die with it in. Like, you'll be happy, your hip will feel great, you got this new replaced hip, and that you'll die at age 83. Because the worst thing for these surgeons is to take people who have an implant that's failed with a very elderly or a frail patient that's not really a good candidate for surgery, but they have a failed implant. So you have to go in and you have to take out an old implant, which, by the way, is sawing out way more bone because they have to take out an old implant. And then they got to put in a way bigger implant. And those are called revision surgeries. And revision surgeries don't have nearly as good outcomes. They're way more side effects. And it's something that I wouldn't wish upon anybody. It's really not fun to do a revision surgery. So surgery, if you do it, I'm totally on board with it. It can be helpful in the right circumstance. I would just try to delay it, so that's where a lot of these treatments come in, is that if you can get prolotherapy and it gives you 2 or 3 or 4 more years, that's a win, right? Because then you're going into that surgery with about better long-term prognosis of what that's going to look like, right?
Yeah. Even the wait times for surgeries, for those types of surgeries now, are crazy long. So while you're waiting, or like maybe you could fix the problem or start to feel better, and then, like you said, prolong that surgery if needed. So
100%. Let's do something about it while you wait.
Always good to know there's other options. It's not just surgery is the only option. So I think that's helpful for people to know. Okay, last question here. Sorry, my computer just froze for a second there. I think I saw something about infrared saunas.
Yeah, infrared dome or infrared saunas. Infrared light is actually very useful. I like it. It's very similar to what I mentioned earlier with low-level laser therapy. Similar type of wavelength of light, a little bit less intense, but it's very useful. I like it.
Yeah, I think just from the heat component too, right?
Yeah. And that question just said for my swollen knees. And so I would question whether or not if it's swollen knees, you might want to dig into what type of arthritis that is for you. Because when I'm saying far infrared light is useful, I'm more talking about the osteoarthritis. Because if you have a really red, angry, warm, painful, swollen joint, adding in more warmth and dilating the blood vessels to get more fluid into that area, it might not be the best thing.
So the cold plunge might be better.
In that case, you might want to go more on the cold side. Yeah.
Awesome. All right. So I think, that just about at 8 o'clock here. So thank you everyone for tuning in. If we did get a chance to get to your question, definitely reach out to Nirvana and have a chat with Erik, book an appointment, and get your pain sorted out. Thank you so much, Erik. That was very informative. I definitely learned a lot. So yes, thank you so much for taking the time tonight.
Thanks for having me. Maybe I can just type in a couple of things on the side here at this chat, because there's a couple more questions that came in.
Sure.
Okay.
I'll
stick around. Just do that.
I can hang around because I'll have to stay on.
You have to
I didn't want to take up your time.
I'm just curious. I like the couple of notes. There's steam rooms. I think steam rooms very similar to the low level laser therapy, heat therapy. Doesn't hurt if it feels good. Generally speaking, with a lot of these things, if you know you don't have a contraindication to doing it, like maybe some sort of cardiovascular disorder where maybe your doctor said don't go into any saunas or steam rooms, or you have diabetes and you can't feel your feet or something like that, that might be a reason you wouldn't want to go into that. Generally speaking, I'm on board for patients to try out these natural things, right? You can try it out, and if it works for you, keep doing it. Right. So that kind of goes along the lines with a lot of gadgets that you can buy online, from TENS machines to different lotions and potions you can rub on it, essential oils or DMSO or Tiger Balm or A535 or lidocaine creams, or is for the most part, usually talk with your doctor before you add stuff, but they're usually worth trying. I'm just thinking, I want to caution you against just blanketly covering up the pain. If you blanketly cover up the pain, it'll pop up somewhere else, and you're not going to like that, and you're going to get more confused when that happens. So if it's just stiffness and I feel relatively good, but I feel a little stiff after I overdo it, a little bit of a warm bath or infrared light or steam room might be amazing, right? Yeah. And then Sandy put, I have 2 hip replacements, which are 22 and 21 years old with no wear and tear. That's amazing. And so at 75, I'm probably looking at revision sometime down the road. Is there anything more I can do other than walking and aquasize? I love that you're doing walking and aquasize and or water walk. I very commonly recommend to my patients, especially people that have any type of low back pain, herniated disc, degenerative disc disease, or artificial hips. Generally speaking, anything that you can do that improves the quality of your blood, which is the things like nutrition, sleep, stress, all that kind of stuff. So the quality of your blood dictates the quality of your healing, right? Quality of your immune system dictates the quality of your healing. So those 2 things, make sure your cardiovascular risk factors are in order, so you don't have high cholesterol, you don't have high sugars, your diet is good, you don't have high inflammatory markers, your liver is good. Those things actually help. So when I said the hip replacements or the knee replacements, a good outcome is 15 to 20 years. That's true, okay? Because some people are going to get a 5-year, or some people are going to get an 8-year, but there's some people that are going to get a 35 years, and they're going to be in the best shape ever, and they can run triathlons with it, right? Like it doesn't mean that you're screwed because you have these older hip replacements and you're still wanting to live till you're 90, right? Doesn't mean that those hips are going to fail ever. Don't let me put that into your head. Just keep doing what you can do to keep the whole body healthy, and those areas probably will be fine. And if they aren't fine, if you're really healthy, you'll be able to handle a revision surgery, right? Because there's some people that are 82 years old and they're way healthier than your 65-year-old going in for a first-time replacement, right? So if you're healthy going into a revision surgery, you might be the surgeon's dream, right? Your outcomes are going to be great. And I also help my patients too. Some patients end up getting surgery. I'm still still kind of walking with them through that process. I'm there if they have any questions. What can I do before surgery? What can I do after surgery? Here's what my PT was saying. Like, what do you think about that? Doesn't feel right, or does feel good? That's a big part of what I like to do, is making sure that you're supported through the process. And I'll just say one more thing about that. Some people are going down to Panama. They're going down to Arizona. They're going to BC. They're paying out of pocket, paying $50,000 or $100,000 for a new hip, a new knee. I'm okay with that. But you're going to need some support, because unlikely you're going to be flying down to Panama. You're going to be flying to go get your regular follow-up, or to go get your PT and to get regular doctor supervision of how that rehab is going. And the rehab in the first 6 months dictates whether you're going to be like Sandy, who has 22, 21 years later and you're still feeling good on the same hip, right? Okay. Is there any other ones here? How much time? Oh, sorry. What are your thoughts on a vibration machine? Talking about the ones you stand on, or like a Theragun percussive device? The vibration machines, I don't have any expertise in. I haven't looked at the research on them at all. Yeah, so Wendy, sorry, I can't really answer that question. I haven't looked into that at all. But again, that would be one of them. If it feels good, you have no contraindications to do it, just keep doing it. And then how much time between spine x-rays is necessary to assess joint deterioration? It's a great question. I would say at least a year. If you have psoriatic arthritis, rheumatoid arthritis, septic arthritis, gouty arthritis, some of these are what's called erosive arthritis. So they actually eat away at the joint. So the longer that flare up happens when you have rheumatoid arthritis, the more erosion happens in the joint. So typically when somebody gets diagnosed with rheumatoid arthritis, they do what's called a baseline x-ray of your hands. And they do that baseline because they can check over 6 months, over a year, over 5 years, over 10 years, how much erosion has happened. Because the erosion leads to deformity, and everybody here is probably familiar with somebody that's had, some deformed hands from rheumatoid arthritis. So they can monitor how well they're actually managing the disease based on recurrent x-rays. With osteoarthritis, it's very rare that they do follow-up x-rays unless you request it, because symptoms have gotten a lot worse. If symptoms haven't got a lot worse, there's no reason to do it again, right? Because you're not treating the degeneration, you're treating the symptoms in that case. I still would be curious to look at it, probably at least a year out, but yeah. Okay, and there was one more question I totally missed up. That was about prolotherapy. How often do you recommend it? Prolotherapy, how often we do it, how many times you need it, depends on you, depends on the severity of your disease, and depends on your response from treatment. So if you respond really, really well and you're out of pain, I don't just keep doing injections for you, right? Like if you're one and done, you're one and done. Typically my patients are 3 to 6 injections, and we're doing roughly one a month, one every 3 to 4 weeks. And the reason we do that is that's typically how long it takes for your immune system to go through a normal healing response. You got a little bit of an inflammatory phase, you got, fibroblast phase, you got a remodeling and repair phase. And that's typically going to go through in the very shortest timeline, 3 weeks. And that's where we check in and see if we need to restart or send your body another signal to continue doing what it's doing. Okay, that's it. Thank you.
That's amazing. Thank you for doing that.
No problem. I felt my OCD kicked in. Need to answer the questions.
Need to answer all the questions. Great. Yeah. Yes. Thank you. Thank you. Yeah. Thanks again, everyone. Thank you, Dr. Nelson, once again. And I will be sending out this recording as well. So don't worry if there's a lot of information, so you can watch it anytime you'd like.
Yes. And our clinic name, I'll put in here.
Yes.
Nirvana Naturopathic Medicine. It's spelt weird though.
I still always want to say like the band.
Exactly. Yeah. That's why I say it's spelt weird.
Yeah.
It's nerve, like a nerve, like in the body, but or neurology. Yeah.
Awesome.
Okay, thank you, everybody.
Thank you. Have a good night.
You too.